So, good afternoon to all. On behalf of National Neonatal Forum of India, Ministry of Health, World Health Organization and UNICEF, and WHO Collaborating Center, I welcome you all on World Prematurity Day session. The first session is a technical session by the experts. So may I ask my colleague, Dr. Deepika, to initiate the session. Over to you, Deepika.
A very good afternoon to all. We have all gathered here on the occasion of World Prematurity Day 2020. Since 2009, this day is being observed annually and globally by the pioneers in the field to discuss glaring issues relating to preterm birth and addressing them with potential solutions. Globally, about 15 million babies are born too soon. India accounts for the highest burden to the tune of 20% of the preterm deaths worldwide. This day, hence, provides an opportunity to focus on the heavy burden of not only death due to preterm birth, but also the complications in surviving newborns. For this year 2020, the global theme for the day is Together for Babies Born Too Soon, Caring for the Future. It focuses on supporting the families, supporting the healthcare professionals, and supporting the healthcare systems. So, for today's session, we will be observing the session in two parts. First will be a technical session, which will be underscoring the means to achieve the third Sustainable Development Goal by management of preterm newborn by India's leading neonatologists. The second session will be the role of stakeholders led by the stalwarts in the field of mother, newborn, and child health policy making. So, we now start the first session, which is managing preterm newborn. For this session, I would like to introduce the moderators. Dr. Ranjan Pejawar, he is the President-elect NNF 2020 and is currently working as a senior consultant in Bangalore. I welcome you, sir. Dr. Sushma Nangia, she is the Vice President NNF and Director, Professor and Head, Department of Neonatology at Lady Hardinge Medical College, New Delhi. I welcome you, ma'am. Here on, I hand over to the moderators to introduce the speakers for the session.
Good afternoon, friends. On this day, 17th of November, being the World Prematurity Day, it is very thoughtful and highly appropriate to have a session on technical issues and a session on advocacy and planning for all those who are concerned with the management and planning of preterm infants. With 3 million premature babies being born in India annually, the morbidity and mortality is very high. The burden on the healthcare system is also very high. And we have to find innovative, cost-effective methods monitored by quality initiative if we have to succeed in managing this burden. We have 5 speakers today, and may I ask my co-moderator, Dr. Sushma Nangia, to continue with the session.
Thank you, Dr. Ranjan. And this is indeed a privilege to be here. And this is so thoughtful of National Neonatology Forum to have a session like this, wherein we have
completed weeks of gestation. And the babies who are born between 34 and 37 completed weeks of gestation are called as late preterm babies. As per the Global Action Report of WHO, Born Too Soon, globally 15 million babies are born preterm every year, and the global preterm birth rate is 11%. That means 1 out of every 10 babies which are born is a preterm child. And if we look at the incidence, most of these babies, more than 84%, belong to the gestational age of 32 to 36 weeks. Between 28 to 32 weeks, 10% of the preterm babies are born, and 5% of the babies who are born preterm are less than 28 weeks of gestation. This is very important to note that 6 countries in the world, namely India, China, Nigeria, Pakistan, Indonesia, and USA, account for 50% of the total preterm births. That means almost 7.5 million babies out of total 15 million babies are born in these 6 countries. And preterm birth rates, as per data published in 2010, the highest preterm birth rate is in Southeast Asia and Sub-Saharan Africa, that is 12.8%. 60% of total preterm births, that is almost 9 million out of 50 million infants who are born preterm, are born in this area, and 9 out of 11 countries with highest preterm birth rates are from Africa. So it is very important to look at how is the global burden of preterm births. Further, though the average preterm birth rate is 11%, it ranges from 5% in Northern Europe to almost about 18% in Sub-Saharan Africa. And this slide shows you the top 10 countries with highest global preterm burden. And as we can see here, India tops the list. We share 23.6% of the burden of global preterms, and our preterm birth rate is 13%. And the country next to us is China. They share 7.8% of global preterm burden, and their preterm birth rate is 7.1%. So we are much ahead of the country which is just below in the rank behind us. Now coming to India, in India almost 3.6 million babies are born preterm every year. And as we have already seen, 23.6% of the world's babies are born here. And as per the NNPD data, which was done in 2002 to 2005, the prematurity is the leading cause of newborn death, and is the second leading cause of death after pneumonia in the children less than 5 years of age. And this NNPD data is the data collected from 18 centers looking at more than 1.5 lakhs of babies in our own country. Now, why do the preterm babies matter so much? And this is because these are babies are born preterm, they are immature. Most of their systems, whether it's a nervous system, cardiac system, respiratory system, GI system, they are all immature. And because of this small tiny baby is surrounded by lots of morbidities. And as all of you know, it is hypothermia, hypoglycemia, they cannot tolerate feeds well, so feed intolerance, respiratory immaturity, which we call it as respiratory distress syndrome, shock, sepsis, necrotizing enterocolitis, patent ductus arteriosus, and intraventricular hemorrhage. So this baby is surrounded by so many problems. The baby has to fight all these problems, and then we have to help these babies to come over these issues. Now, if we look at, so they have so many morbidities. If we look at mortality, in world 1.1 million babies die from preterm birth complications. More than 80% of the world's preterm death occur in low middle income countries, and the risk of death is 12 times higher in African baby as compared to an European child. So what is 90-10 gap? So it is described that 90% of the babies who are born less than 28 weeks of gestation survive in high income countries as compared to only 10% of the babies surviving in the low income countries. So this is called as 90-10 gap. Now the preterm babies who survive, they are at increased risk of neurological disability. All of us have managed these babies, seen these babies, and we know how difficult is the life for this baby and also for the parents when these babies have neurological problems. They also have visual problems, like you know that they have retinopathy of prematurity, myopia, so many optometric problems. So they have increased visual problems. They have hearing problems, and at times these hearing problems go unnoticed and might be picked up at the school age if the routine hearing screening is not done. And we know that they have again learning disabilities which are also picked up at the school going age if if it is not picked up earlier, if they are not screened earlier, these babies face a lot of these problems and they have a lot of issues at the school going age, and also family, mother in the family has problem because of that. So what is the Lancet 2019 tells us? That yes, the preterm births are increasing. They have increased from 9.8% in 2010 to almost about 10.6% in 2014. And this slide shows us the 11 countries where the preterm birth rate is more than 15%. And that's why it is said that, the premature babies is a public health problem, relatively unrecognized public health problem. The community knows the public health problem, mostly in adults like diabetes, hypertension, but the small preterm babies is an unrecognized public health problem, and we require more and more attention on this public health problem. So if we look at what have we learned so far, is that globally 15 million babies are born preterm. The global preterm birth rate is 11%. The six countries, India, China, Nigeria, Pakistan, Indonesia, and USA, account for 50% of the total preterm births. In India, over 3.5 million of babies are born preterm every year. The preterm birth rate is 13%, and globally 1.1 million babies die from preterm birth complications. And these preterm births are increasing, and they are almost more than 11%. So we know that our policies, our government talks about sustainable development goal 3, which is ensuring healthy lives and promote well-being at all ages. And we also have goal within the goal. And if we look at goal 3.2, talks about ending preventable deaths of newborns and children under 5 years of age, with all countries and as low as 12 per thousand live births and under 5 mortality as low as 25 per thousand live births by the year 2030 to 2030. And the goal within the goal 3.4 tells us reducing the preterm mortality by 1/3 by the year 2030. So we have this huge goal against us, and then to satisfy this goal, to fulfill this goal, we have today's session, and the subsequent speakers are going to tell us that how we will be able to manage this baby and how we will be able to reduce preterm mortality, preterm morbidity, and ensure that these preterm survivors have intact survival. And if we have to achieve this, then everyone has to play a role. So we have a policy makers, they have to have policies for the management of preterm babies. They have to have training modules as we have for, the facility-based newborn care. So we expect this from policy makers. As a healthcare workers, we have to take care of, the management of preterm babies, and simple modifications or simple interventions like kangaroo mother care, helping these babies breastfeeding, lot of quality initiative to support all this will take us a long way. And finally, coming to the community, that community also, the people should be aware about the preterm babies, their problems, their survival, and how can we reduce their morbidity and mortality. So this is what I have to say about burden of prematurity. Thank you very much.
Thank you, Dr. Ruchi. And you very well highlighted the burden of prematurity, and we are all aware now that prematurity is actually on the rise. And there are multiple reasons that you have women who are working women getting married late, they're conceiving late, and with the presence of the artificial reproductive technologies available, they are being used, and there are multiple births. So all this is adding up to the burden, and you very well summarize the burden for all of us, and we will see how the subsequent speakers are going to deal with the next aspect that we have to talk about. I'll request Dr. Ranjan Pejawar to introduce the next speaker. Thank you, Dr. Richi.
Thank you.
After the initial talk describing the burden of prematurity, we now have the next talk on WHO standards of care for small and sick. we always look up to the WHO to give us a standard for all the healthcare aspects and various healthcare aspects. So even today, we are going to ask the WHO person, Dr. Deepti Agarwal, to tell us about the WHO standards of care for small and the sick. Over to you, Dr. Deepti Agarwal.
Well, good afternoon, everyone, and thank you, Dr. Pejawar, for that introduction. So the theme of today's webinar is do no harm. And I think first, do no harm is the first criteria for any quality to improve healthcare. Just take a moment to. So all of us participating in this webinar today are associated with newborn care in different capacities, as service providers, as program managers, as trainers, and as assessors. So the basic question that we must all ask of ourselves in context of quality is, are we providing the best possible care to the newborn? Is this medical care in compliance with what other healthcare providers would do for newborns in the same circumstances? Are we following clinical practice guidelines? What can we change or improve to deliver better quality care? And how do we measure the quality of services that we provide? All these questions can be answered if we have well-defined standards of care. In simple language, standard of care is a general description of what is expected from the health system in order to ensure high quality care for newborns in each domain of quality of care field. In the next 10 minutes, I shall introduce to you the WHO initiative of developing quality standards for small and sick newborns in health facilities. Although this is WHO's work, this has been informed by neonatal experts from all over the world, and there's a lot of very significant contribution from India, including from Dr. Devrari, Dr. Chesdeva, Dr. Navia, and Dr. Mani. So that contribution has been acknowledged at all levels. All of us are witness to the impressive gains that we have made in establishing, scaling up, and strengthening of newborn care facilities since 2011. We all are now managing nearly 1.1 million newborns in our health facilities. We have also established a well-functioning information system, which is the SNC Online. However, a criteria of measuring progress has focused on a few domains only: the infrastructure, number of providers, number of trainings, equipments, essential supplies, and so on. While these are at the foundation of facility-based newborn care, it is now time to focus on the issue of quality of care or services that we provide through our facility. The standards that I am introducing today provide a very important and valuable resource for healthcare professionals, program managers, professional bodies, and technical partners involved in newborn care to help plan, deliver, and ensure the quality of health services. How will these standards really help us? What is the aim of these standards? They will help us to determine what is expected and required to deliver effective, high quality services. And once we have made facility assessments, they can help us define the priorities for improving quality of care. They will also help us identify what can be tracked and monitored and to assess the performance in terms of quality, an area in which we have been struggling for quite some time to come up with good measurements and find a basis for facility accreditation and performance-based incentives to our doctors and nurses in the facilities.
Not changed.
What's the scope of these standards? These standards place both the newborn and the family at the center of care by improving both the provision and experience of care. They cover, the important thing is they cover all newborns delivered in health facilities as well as essential newborn care starts right from the time of birth. Therefore, these standards apply to all health facilities where deliveries take place. These standards are equally relevant for care of all preterm and low birth weight babies who do not have any complications and for the management of complication in any newborn. They can be adopted for all delivery points, private accredited facilities under Ayushman Bharat, and newborn care facilities at all levels. These set of standards are currently relevant only for inpatient care and do not really apply for community and home-based care. And lastly, the hallmark of these standards is that they are consistent with WHO quality of care framework. Now, to provide an overview of the standards, these standards for newborn care are based on 8 domains of WHO framework for improving quality of care and address the most common conditions that affect sick and small newborns in health facilities. As you can see at the top, the standards are a critical component for health system strength. We consider three important and interdependent domains of quality of care. The first domain is the provision of care, which ensures that health facilities provide standardized care within an integrated network of newborn care facilities. This domain includes three standards. The first one is of evidence-based practices for routine care as well as for management of newborns. Online portal that enables collection, analysis, and use of data for early and appropriate action, and a well-functioning referral system that can ensure continuity of care, including during transport. Equally important from the perspective of the users, the mothers and the newborn and the families, is the care, is the experience of care. The experience of care has been modified in the standards to ensure that the developmental and emotional well-being of the newborn is taken care of. And the three key standards under the experience of care address the issues of family-centered care, effective communication with the families, and managing pain and distress in sick and small newborns such that developmental supportive care is provided and these sick and small newborns are followed. Underlying these two domains and making the provision of care and experience of care possible are the competent, motivated, empathetic, multidisciplinary human resources who are consistently available to provide this care. And finally, all this would not be possible without a standard that ensures that there is appropriate physical environment and resources for sick and small newborns. As you would see that each standard has two main components. One is the quality statement and one is the quality measure. Quality statements are very concise statements for improving the quality of care for newborns in a very measurable way, while the quality measures are indicators for assessing and measuring quality as specified in the quality statement. And as we know, we measure in terms of input, process, and outcome. So this is how each standard has been organized, and this is how you can follow it in the document. Now, lastly, coming to the most important aspect, how do we apply these standards in context of newborn care in India? There are 8 standards and about 80 quality statements, and that really brings us to how do we follow up from here. So these are some of the ideas for moving forward with implementation of small and sick newborn care, and based on these standards of care provided in the WHO framework. So I think the first step would be to develop a broad agreement among stakeholders that there is a need to adopt and adapt standards for newborn care facilities. We should start a process of discussion which would be led by a national technical working group under the mandate of MOHFW and led by the top technical and academic institutions. The implementation would have to take a stepwise approach. We could start with assessment of quality of care either at facility level or district level. And based on this, we identify priority standards that we can implement immediately or in the first phase. Also, here comes the role of the national, regional, and state collaborative centers who need to ensure on-site support to the newborn care facilities who take on the task of implementing these standards. Also, we need to see that some of these indicators or measures are included within the existing data system and that we are able to improve data quality use by our facility and district health managers. Also, we could start recording the best implementation approaches facilities or states or districts that have taken a lead on. At the larger national level, we need to integrate quality aspects in our national capacity building programs and also see that we can integrate some of these standards in the national quality assessment and accreditation process. Lastly, we also need to see that in any subsequent roadmaps and operational plans, we include quality as a very important component. So this is all from my end. We all will have a role to play. That is the only way to reach where we intend to reach in terms of providing quality care to all the newborns. Thank you.
Thank you, Dr. Agarwal. That was a very crisp and concise presentation. You first explained to us what was standard of care, and then you spoke on the various aspects of implementation. The phrases family-centered care, developmental supportive care, and follow up in the community, I thought were one of the most important steps. And you also emphasized the quality initiative which are required in every step of this implementation. And finally, you said that a team approach is very important for ensuring quality care and result in intact survival of these tiny preterm infants. Thank you very much. And I now request Dr. Sushma Nangia to introduce the next speaker.
So, yeah, my privilege to introduce Dr. Srinivas Murki. Murki is a great friend, and he is the person known regarding prematurity, person known for teaching CPAP across the country, and he will be speaking to us right now on best practices for preterm care. And as I have always said, these best practices should not remain just in the modules, or they should not remain just as something which is being taught. So, no better person than Murti to talk about it, because when he talks about best practices, you actually see them being implemented in his unit. So, Srinivas, over to you. Unmute yourself, please.
Thank you, Dr. Sushma, for those kind words, and it's my privilege to be part of this August gathering. And I welcome all the audience, including the doctors, nurses, and other healthcare people for this important conference and meeting. So, best practices for preterm care is the need of the hour if you want to improve both the survival as well as the long-term outcomes. What do we mean by best practices? These are interventions, when implemented in full, improve the survival, not only the survival, immediate and long-term outcomes of preterm infants. And this requires a continuum of care, right from prenatal to natal to postnatal interventions. I will look at some of these interventions in this format. Now, looking at some of the best prenatal practices, they can be broadly classified into those that reduce the preterm births, those that improve the outcome of preterm birth, and those that ensure the quality of care for long-term outcomes, and also for some immediate outcomes. The measures to reduce the preterm birth are the care of the girl child and the WHO's 8 antenatal guidelines or antenatal visits guideline.
क्या हो गया भाई? फिर भी चल रहा है या नहीं चल रहा?
सिस्को वेबएक्स से चल रहा है कि वो नहीं सब कुछ सिलेक्ट्स ओ नो पूरा इंटरनेट चल रहा है सर इंटरनेट बंद हो गया होगा चल रहा है उसमें लाइट चली गई इंटरनेट चल रहा है वो चल रहा है नहीं वो सिस्को वेबएक्स तब तक चलेगा जब तक ये लैपटॉप है
अच्छा लाइट चली गई हाँ
पूरी बिल्डिंग में लाइट नहीं है नेट आ रहा होगा ना तो वेबएक्स
उनका चल रहा होगा
हमारा चलेगा तब यूपीएस पे चल रहा होगा तो हमारा
अच्छा कौन सी लाइट आई कमल
ये तो इमरजेंसी है
आ गई ना
लाइट आ गई हां टोटल आ गई हमारा बात तब भी नहीं हुआ
दोबारा से
चल रहा है
हाँ वो
चलेगा वो नेट चल रहा है
नहीं यूपीएस पे है
तो भैया अभी हमारा भी तो चल रहा है
ऑन कर दे भाई
ये वाला ऑन करना सर का
मतलब हमें नहीं पता चल रहा है ना
यूट्यूब में तो चल रहा है
मतलब सेशन चल रहा है ना
सेशन चल रहा है आपका टोटल
बस ठीक है
हो जाएगा रिसेट
इसको भी ऑन कर
ऑडियो लगाओ हमें
तो वेबएक्स तो चल ही रहा है
तो सेशन तो ऑन सेशन तो ऑन
Okay. क्या हो गया? ऑडियो नहीं आ रहा? इसमें आ रहा? नहीं। वो भी रुक गया।
अभी हैंग हो गया है क्या?
क्या?
ये चल नहीं रहा सेशन।
नहीं, वो लाइट नहीं होती ना इसलिए। वो उसमें यूट्यूब में
तो आ रहा नहीं आ रहा यूट्यूब में।
पुनीत यूट्यूब में हैंग हुआ क्या?
इसमें तो नहीं आ रहा। चल रहा है? फोन में देखो एक बार।
हैंग हो गया।
नहीं आ रहा। ये चल रहा है।
रोकना पड़ेगा। हाँ, आप अनम्यूट करके सो जाओ। दीपिका एक बार डॉक्टर मूर्ति को बोलो 2 मिनट रुकने के लिए।
क्या हो गया?
बोलो ना।
वो यूट्यूब का कनेक्शन कट रहा है, रीस्टार्ट करना पड़ेगा। हाँ।
खत्म ही होने वाला है उसका। अनु
उसके बाद फिर करें सर।
यूट्यूब का साउंड आ रहा है?
साउंड आ रहा तो सेशन के बाद बोल देंगे।
क्यों आपको म्यूट क्यों करना है?
नहीं सर, वो यूट्यूब पे सर उनका साउंड नहीं आ रहा है सर, इसीलिए वो एक बार रीस्टार्ट करना पड़ेगा सर, इसीलिए।
तो सबको लॉग आउट करना पड़ेगा?
नहीं, सबको ही लॉग आउट नहीं करेगा, उसी लिंक पे खुलेगा सर।
अच्छा।
हमें सिर्फ लिंक दोबारा से मतलब सब कुछ सेव है।
सुषमा कुछ बोल रही है यार, सुनाई नहीं दे रहा। कॉल करना।
क्या बोल रहे हैं? हम लाइव कर रहे हैं, आप 1 सेकंड के लिए सेशन पॉज करा दीजिए, हम रीस्टार्ट करते हैं।
यूट्यूब पे आवाज जा रहा है हमारा? अच्छा, यू कैन हियर इट इन यूट्यूब। अच्छा ठीक है ना, ठीक है, हम अपने आप को म्यूट करते हैं। ओके म्यूट करो। काम करो, हमको सुन रहा है, यूट्यूब पे भी जा रहा है। म्यूट करेगा। म्यूट करो। किसी और को होस्ट बना दो। हम लीव कर देते हैं मीटिंग, किसी और को होस्ट बना दो। मैं आपको बोलती हूँ, रुको मैम, हमें 2 मिनट दो। मीना भी कह रही है कि सब कुछ सुन रहा है, हमें आपकी आवाज भी सुन रही है, तो हम मैम को होस्ट बना के लॉग आउट करते हैं। हम आपको होस्ट बना के खुद लॉग आउट कर रहे हैं, सब कुछ चलता रहेगा, ठीक है ना भैया? ओके मैम को होस्ट बनाओ, हम खुद लॉग आउट करते हैं, फिर रिजॉइन करें। क्रॉस करो, लीव मीटिंग करो ना, एंड मीटिंग में लीव मीटिंग करो। चलो अब करो जी फटाफट लॉगिन, जब तक मैम नहीं।
अभी चल रहा है सेशन मैम, उसमें भी दिखता है अभी चल रहा है, मतलब वी कैन हैव टाइम।
मतलब 2 सेकंड ये जस्ट
हाँ मतलब वी हैव टाइम, ही इज जस्ट कंप्लीटिंग।
वो भी सॉन्ग होती है। ये तो बड़ा लाइट है।
इसके बाद जब शुरू होगा दिखा देंगे। Percent of deaths in preterm babies because of sepsis, malformation, and extreme preterm. So I think there is some echoing again. Can we ask the WHOCC to mute? Yes.
WHOCC, please.
So another 50% of deaths in preterm is because of sepsis, malformation, and extreme preterm. I'm sure that extreme preterm are the babies who should be managed in only level 3 centers or in medical colleges. But rest of the babies can be easily be managed in the SNCUs, and for that we need to work on improving sepsis rates or decreasing sepsis rates, and sepsis is preventable. And how do we prevent deaths due to sepsis? By using early antibiotics if there is a premature rupture of membranes, having clean labor rooms,
rooms, enteral feeding with mother's own milk. This intervention needs to be upgraded. I'm sure all of us have the will, but I'm sure that this needs to come up in the next program, that how do we ensure that every baby gets his mother's milk if the baby is born preterm. Kangaroo mother care, almost all the SNCs are now having kangaroo mother care. We are all highlighted the importance, and it becomes big part of routine care of preterm. And one more very important thing is reducing admissions, reducing NICU stay, and reducing antibiotic usage. We have started with primum non-sterile. So I think this is the area where we work on. We need to decrease admissions, NICU stay, and antibiotic usage. The Laksh program is a very important program to improve the labor rooms. And since Laksh program concentrate on term babies, I would suggest that having blenders, pulse oximeters would be an added addition if you want to improve the care of preterm in the labor room. This should be the way the labor room should be looking at. No more we can accept labor rooms like this in our hospitals anymore. And as I said, mother's own milk is the thing which will not only decrease the mortality, morbidity, but also empower the mother to take care of her baby, and also ensure that the long-term outcomes are better. It decreases NEC, decreases late onset sepsis, chronic lung disease, retinopathy of prematurity. What happens before birth is steroid, antenatal steroid. What happens after birth is mother's own milk. And how do we improve the mother's own milk? I feel there is a need for, I'm last minute. Yeah. I feel there is a need for a dedicated lactation nurse for every NICU. If all the tertiary care NICUs start having one dedicated lactation nurse, we can improve on the mother's usage of mother's own milk. This is one comprehensive milk bank which we have in Nilafar Hospital, which has definitely changed the way babies are being fed. Nilafar Hospital has a tertiary care NICU, which is formula-free NICU for the last 4 years. Kangaroo mother care, I don't have to stress on this. This is everybody's pet project, and I'm sure that it is already showing dividends. Many of the SNCs already have good kangaroo care units. They are doing good job. Mothers are empowered, families empowered, and we are seeing good dividends out of it. We don't want any more these postnatal wards where mothers are sitting or the family is sitting with the baby. We want them on their lap or on the breast. The last one is to reduce admissions. If 25% of SNCO admissions of jaundice are there, I think we are not working well. We need to manage these jaundice babies in the FRUs or in the labor rooms or in the places where babies are being delivered. The rest, 50% are getting antibiotics in the SNCUs, whereas only 7% of admissions are sepsis. So that means there is almost 5 to 10 times higher antibiotic being used. We accept it can be 2 times or 3 times, but 10 times is significantly higher. And there is a role for all the QI masters to work on this. I'm sure Dr. Vikram is going to speak a lot on QIs where antibiotic usage, mom and labor rooms are going to improve. The last is reducing antibiotic usage. Do not use it prophylactically. Do not rely on CRP. And to summarize, prenatal practices, primary prevention, take care of the girl child. Secondary prevention, progesterone circlage to prevent. Magnesium sulfate, antenatal steroids, in utero transfer. Natal practices, delayed cord clamping, cling wrap, mother's expression of milk, CPAP blender and pulse oximeters should be added. Postnatal practices, I hope that we develop cost-effective models for postnatal transport, have CPAP in every medical college, in every SNCU, have a lactation nurse for every NICU. Kangaroo mother care units are coming up, and all the step downs have become kangaroo mother units, and QI should be concentrating on reducing stay, admissions, and antibiotics. Thank you.
Thank you, Srinivas. I know we had given you a mammoth task of talking on best practices, and you've covered that very well, right from the antenatal practices, the intrapartum practices, and what needs to be done in the SNCUs or in the NICUs. And we had done this kind of a webinar with the Ministry of Health, where we had the audience as the district hospital or the SNCU people, and we actually showed them in your state the antibiotic usage is this much, and sepsis rate is so much, and similarly KMC and other things. So you've covered it beautifully. Thank you very much. And I know there are no questions, otherwise there will be questions on this aspect. So thank you so much, Srinivas. I request Dr. Ranjan to please introduce the next speaker. We are running a little short of time. I think the WHOCC will allow us 5 extra minutes to be able to complete the session. Yes, Dr. Ranjan, please.
Good afternoon once again. It is my proud privilege to introduce Dr. Praveen Kumar, who is very well known to audiences of all nature who are involved with neonatal care. He is a professor of neonatology at Chandigarh, a sought after teacher. He must have trained hundreds of postgraduates, scores of DMs, and his fan club is vast. He has been the nerve center of clinical practice guidelines in the NNF. He has initiated it and managed it for several years now, and it is an ongoing project. And best of all, he's a very humble and down to earth man. And that is my good friend, Dr. Praveen Kumar. Over to you to speak on clinical practice guidelines.
Thank you, Dr. Ranjan, and a very good afternoon to all of you, and wishing you a very happy National Newborn Week, which we are celebrating, and today is one part of that. NNF has been working on evidence-based clinical practice guidelines for more than a decade now, and I would just kind of highlight the few of the activities which have been undertaken as part of the NNF mandate. So the first fundamental question is, why do we need to have clinical practice guidelines? So in this era, when we are flooded with information and thousands of papers being published every day, and most people being able to access them so easily now, so there's an information overload. And it's impossible virtually for anyone to keep pace with the amount of papers or new evidence being published. Even if somebody was too smart and used latest gadgets and high internet, etc., I think the evidence needs to be transformed into action items. Without that, it's useless. So the basic idea of having clinical practice guidelines is to provide contextual guidance for best practices based on evidence. We will have guidelines from several countries, UK, USA, etc., but they cannot be applied straight away to our situation. So to develop a guideline, we need to look at our context, our healthcare system, our facilities, the manpower, etc. So NNF has been trying to fulfill this gap by providing evidence-based clinical practice guidelines. We also know that clinical practice guidelines help to minimize variations in practice between institutions and between individuals, and that's another way of trying to improve the quality of care. So in short, clinical practice guidelines provide us evidence-informed, contextually adapted content for quality of care. The forefathers of NNF were very far-sighted, and right in the beginning, in fact, they listed that one of the mandates of NNF was to draw out recommendations for neonatal care at different levels of care. And at NNF, this talk went on for several years till a very concerted and organized effort was initiated somewhere in 2009. And by the end of nearly 18 to 24 months of exercise, which involved more than 100 expert neonatologists and several experts from allied specialties like ophthalmology, microbiology, or maybe radiology, we had guidelines published on 21 practical topics. So as was the practice at that time, these guidelines gave recommendations for different practice questions and described the level of evidence available at that particular time. After an unintentional gap of nearly 8 years, this activity was revived with renewed vigor. And in the year 2019, again involving an exercise, I think spanning more than 12 months period, 7 topics were updated. This again involved a large team of multidisciplinary experts. The highlight of this particular exercise this time was that the methodology was made very rigorous, and the standard of developing clinical practice guidelines using grade methodology was adopted. So in short, each of the guideline development group identified some clinically relevant practical questions. They gave some outcomes which were prioritized and scored very objectively. and then did literature search in a systematic manner, which was transparently documented. Then evidence profiles were generated using RevMan, and then using the GRADE software, evidence decision framework was created and draft recommendations were made. These were then peer reviewed by a few experts and also put on the website for feedback from the users. They were also shared with some of the SNCU doctors and nurses to get 1:1 feedback. And finally, they culminated in the production of this guideline. So all the groups followed the WHO recommended guideline development process, with the main idea was that they should be, all the guidelines should be very objective, should be reproducible, and should be coherent with the process. The whole activity involved a lot of work, a lot of online meetings, training sessions, as well as face-to-face meetings, discussions, group work, and training sessions. These are few of the cover pages of few of the guidelines which were produced. These ones are more relevant to directly related to the care of the preterm baby. For example, feeding of the low birth weight neonate or breast milk feeding for the preterm neonate. And similarly, the CPAP guideline, which was expanded to include all of the non-invasive respiratory support for the preterm baby, prevention of infection, and as well as the very important topic of retinopathy of prematurity. Each guideline followed a very uniform, structured presentation. So starting with the executive summary, key recommendations, then description of the scope and the target audience and the population of interest, some details of the methodology, listing of all the questions which were identified by the groups and the outcomes, and then followed by each practice questions, its summary of evidence tables and the recommendations and the bibliography. This is one example of a summary of recommendation table from one of the guidelines, where each recommendation is tabulated along with, and it's qualified by the strength of the recommendation and the quality of evidence which was available at that given time. Now, while this was going on, NNF also rose to the challenge of COVID-19. And in the month of February, NNF decided that we must have a guideline for the COVID-19 management. So NNF invited collaboration with FOXI and IAP, and under the leadership of NNF actually, and using the expertise which had been developed over the last development of guidelines, the first version of COVID management guideline came out at the end of March, and this was achieved within a period of 6 weeks, but yet adhering to the GRADE methodology. Over the next 6 weeks, due to the ongoing evolution of the evidence, as well as the user feedback, a revised version was introduced, which is still kind of circulation. And you will be glad to know that the COVID-19 guideline created by NNF in collaboration with other two organizations was recognized as the best COVID-19 guideline from 17 countries across the world. And this is the article which was published in Acta Pediatrica, which looked at guidelines from USA, UK, and all the developed countries, as well as India. And you can see the score achieved by the Indian guideline was far ahead of any other country's guideline. Now, we may create guidelines, but unless they are easily available to each user, they are obviously useless. So for dissemination, these guidelines were compiled in the form of books, which were distributed free of cost to the members and other organizations. All these guidelines have also been placed on the NNF website for to easily download and print. Journal of Neonatology has started to publish these guidelines in their issues. And also, NNF CPG app has been created both for Android as well as the Apple platform users. And all these guidelines are available freely in these platforms. To make it easier for the end users, our team is also working on developing some infographics. So I would especially mention two people, Dr. Venkat Kalam from Hyderabad and Dr. Sindhu from Puducherry, who are putting in a lot of efforts. And as a sample, I have put in this infograph for the breast milk feeding of preterm baby and one for the early use of CPAP compared to delayed CPAP. And you can expect to see more comprehensive infographics coming up in the next few months. We are currently at a very advanced stage of completing the work on another set of 8 guidelines, in which 3 are actually new topics which have not been taken up previously. And very important topics, for example, parent and family communication have also been incorporated. And we hope to complete this work in the next few weeks. Because of the COVID pandemic, we had some setback, but now all the groups are again working on it, and we hope to complete in the near future. In the further improvements, we would also like to try to improve our guidelines further and make sure they comply with all the elements of the world standards for clinical practice guidelines. Especially, we need to work on involving the parent groups as well as legal experts. Any feedback, suggestions from users or any other members are most welcome, and I'm sure they will help us to improve this guideline and quality further. Thank you very much.
Thank you, Dr. Praveen Kumar. You have given us a detailed outline about the genesis progress of the clinical guideline preparation by the Neonatal Forum of India. And thank you once again to spearhead that activity. And we look forward to this quality work to continue and help one and all in management of the newborns in a systematic and evidence-based manner. Thank you, Dr. Praveen. Dr. Sushma, the last speaker.
Yes. Thank you, Dr. Ranjan. And continuing with the session, which is going on very well, the last 4 speakers have done a wonderful job. Now I have the privilege of inviting my very dear colleague, Dr. Vikram Datta, who has been working in the field of QI for quite some time, and he has done laudable work in quality improvement initiatives across the country. He has been associated with the Lakshya initiative, and he is doing great work related thereof with the Ministry of Health and Family Welfare. Since we are running short of time, I'll request Dr. Datta to start his presentation and enlighten us on the QI initiatives. Dr. Datta, please. Unmute yourself. Vikram, please unmute yourself.
Okay. Yeah, sorry. So thank you so much, Dr. Nangia. I'm sure I'm audible now. So all my friends in National Neonatology Forum and all the participating teams, warm greetings on the occasion of the 21st National Newborn Week. I have been given the task to cover the topic of QI initiatives. I'll be very quickly moving forward from here. I bring warm greetings from the Nationwide Quality of Care Network, which is a network across 15 states in India. And this is the NQCN Point of Care Quality Improvement Platform, which is a group which has been formed for the first time in India to spearhead the quality improvement movement across the country. So coming straight to the topic, basically we all know that quality improvement can prevent 75% of newborn deaths if we give high quality care. If I translate this to saving preterm lives, it means we could save around 0.65 million preterm lives. Well, that's a large number of preterm lives which can be saved only if I give high quality care. Now let's see, high quality saving UHC. Can UHC or universal health care save lives? Well, the answer is yes. We all know that the SDG 3.8 talks about universal health coverage. So the various interventions which Dr. Murki was talking, the best practices, which Dr. Praveen has also been talking about, the guidelines and the recommendations. If we focus just around the care around the birth, we can get a 46% reduction in the maternal mortality rate and a 40% reduction in the stillbirth and neonatal death reduction. So this is a large number, close to 50% of our maternal mortality and neonatal deaths can be reduced. And if I translate this into lives, this comes to nearly 3 million lives of mothers, newborns, and stillbirths all combined, which could be saved just by giving high quality maternal and newborn care. Well, that brings me to the crux of the issue that we all need to focus on delivering high quality care. Just revising from where my previous speakers, Dr. Nanavati and Dr. Murki, Dr. Devrari sir, and Dr. Praveen, these are various guidelines which have been made. But the need of the hour is to translate these guidelines into action. And the action, and not only the action, but also to reduce the no-do gap. We know this much, but we do this much. We know the guidelines, we have access to the best knowledge, but when we are acting, it is not acting and rising up to that level. Well, what does Lancet say? Lancet says that across the low and middle income countries, people know the best evidence-based guidelines, but less than 50% of the people comply to these guidelines. And that is where the problem is. If less than 50% read the guidelines which have been prepared so painstakingly by NNF, what is going to be the net result in the NICUs? Well, it's anybody's guess. So what does that bring us to the next part? The next part is that how do you improve the health worker performance? Well, you improve the health worker performance. It's a beautiful study which was published in Lancet in 2018. It says you do whatever, you do a technology based study, you give them printed information, you train them, not more than 10% are going to change. However, if you improve the clinical training and add quality improvement to it, more than half of your health workers can improve their performance. And that is why we are advocating for quality improvement, because look at the effect sizes. We've been doing all of these things. We've been monitoring, we've been giving them incentives, giving them printed material, technology-based strategies, nothing is working. So the need of the hour is to focus on the green box, and that is quality improvement plus clinical training. Now, if we are starting our QI journey, where do we focus? We have to focus on this 50%. Now, when I say this 50%, it means that when you tell something new, suppose we come up with a new clinical practice guideline by NNF, 2.5% of the people are going to rapidly pick it up even without Dr. Praveen telling them. They are going to pick it up and they are going to read it and start doing it on their own. 13.5% of the people will get impressed. They'll say, yes, something new has come. They will adopt it very quickly. And then 34% of the people will, seeing these 16% of the people, the 34% of the people who are called the early majority are going to pick it up. Well, this is the 50% we have to focus. So any intervention with the organization does or in your hospital you are doing, try to focus on these innovators and early adopters, which are only 16% people. Once you get this critical mass, you will influence the next 34 people. And once you've got the tipping point crossed, 50%, the others are going to follow, but they're going to follow late. And if you continue concentrating on the laggards, that is the last 16%, you're going to waste your effort. So quality improvement says that focus on this part and forget about this part. So that is what is one important message I wanted to give on the implementation side part of the clinical practice guidelines, the beautiful guidelines which NNF has made to save preterm babies. How do we focus? How do we implement? Where do you focus? Well, we know there are a lot of common challenges in preterm units which are potentially manageable by QI initiatives. Murki has just been telling you all about it. Dr. Nanavati also told you about it. I'm not going to repeat this because of paucity of time. We all know the biggest killer for a newborn in the neonatal ICU for a preterm newborn is hypothermia sepsis, birth asphyxia, necrotizing enterocolitis, IVH, and feeding problems. And these are certain areas which can be beautifully, handled by simple QI initiatives, which will not require any additional resources. Now, I want to very quickly share few QI stories which are going to show you the impact of quality improvement interventions. And what you see here is the work from my own unit, Dr. Sushma Rangia, myself, Professor Arvind Sally. We achieved a 90% reduction in moderate hypothermia, which led to a 40% reduction in deaths per 1,000 patient days and a 71% reduction in late onset sepsis per 1,000 patient days, with a simple intervention of just keeping the babies warm on arrival to the neonatal ICU from the labor room. We used the life-saving tool, and this found that 84 additional babies were saved in our hospital with one intervention. Just think, if we create a collaborator of this across the country, across the entire NNF network, how many lives could be saved? Got published at multiple places, WHO, BMJ, and that is the importance of this. We tried to again focus on care around the birth strategies, which Dr. Murki was saying in the state of Meghalaya, got published in Oxford Journal. We were focusing on kangaroo mother care, increasing the duration, early initiation of breastfeeding, skin to skin contact, some results. The whole paper is cited here. People can go and watch this paper. It's very interesting. Results from some of the Lakshya teams. Dr. Murki was talking about the labor room quality improvement program of Government of India. And I'm proud to share here that we are heading the national mentoring group for the Lakshya and leading the quality improvement revolution in the country across not only the neonatal ICUs but also the labor rooms. And what did we achieve? Some results. Murki was talking about the Nilofer Hospital. Well, beautiful quality improvement work is being done there. And I should compliment Dr. Hema Bindu Singh, her team, and the UNICEF team in Telangana for this reduction in HIE in inborn babies, significant reduction in HIE. In Banaras Hindu University, significant reduction in neonatal deaths due to sepsis to the tune of 70% in Institute of Medical Sciences, Banaras Hindu University. The results are not only there in the district medical colleges, but also in the district hospitals. You can see in a district hospital in Madhya Pradesh, again, the work was supported by UNICEF. There is a mean facility mortality reduction by 28% and a mean stillbirth rate reduction of 41% in the labor room. We were also talking earlier about a reduction in length of stay, 2 days, length of stay reduced in Jabalpur. Significant increase in the kangaroo mother care, much above the goal which was there in a district hospital in Jabalpur, much above the goal. And this is simple, peripheral hospitals, resource constraints, hardly any nurse-patient ratio favorable. ROP screenings, again a major problem in preterm babies at GTB hospital, got published in Indian Pediatrics in 2018. Significant increase in the ROP screening rate. The lowest rate was 14.3%, increased to 66-67% just with QI. Mother's own milk. Dr. Murki again was talking about.
I think there is some interruption in internet. Dr. Pejawar, can you hear me?
Yes, I can hear you.
I
Sushma,
think there is some disturbance at Vikram's end.
yeah, there is a problem at Vikram's end, internet connection.
I think you can audio after that.
That's better.
Yeah.
Dr. Vikram, can you hear us?
Sushma, can you phone him and ask him to only use the audio? That way it may be better.
Yeah, I'll just get this.
It will utilize minimum bandwidth. That will help.
Yes. राहुल कहाँ है? जरा डॉक्टर विक्रम को बोलो कि सिर्फ ऑडियो यूज करें. बोलो फटाफट बोलो, उनका स्क्रीन यहाँ पे आवाज नहीं आ रही.
Sushma, till that time, you can summarize what he has been talking.
Yeah. Yes, I will do that. So we've seen a lot of examples which.
Sorry to inflict, but it is one of the what is using device which is causing disturbance.
One of the.
Sorry?
But is using two devices. That's why you are getting double.
So if everybody else can mute themselves except the speaker, it will be better. And then we won't get this. So we have seen a lot of examples which have.
I think WHO.
WHOCC, please mute yourself. I can't see the mute sign. Yes, that's better. So we saw Dr. Vikram explaining and showing a lot of examples of QI from across places and for different topics. So this is a very good initiative and it's caught on very well with most of the neonatology fraternity, and they are having this being done across the NICUs and SNCUs. So it's absolutely fantastic that this kind of a movement goes on. But my only worry remains that when we are able to sustain them or not, because in the mission mode, all of us end up doing a lot and then we achieve some result, and thereafter this needs to be looked back whether sustaining improvements has been achieved or not, which is actually the fourth pillar of the whole QI thing. So we need to ensure that whatever gains have been achieved need to be sustained, so that when the next thing is taken up, the previous one remains, and you already have consolidated some gains from whatever effort has been put in for the last QI that was done. So I think we are running out of time. We are already at 4:12, 4:13, and Dr. Dilari gave us a grace of something like 15 minutes to wind up this session. So in between, if Dr. Vikram comes back, we can have him speak for another 2 minutes. Otherwise, what we are going to do is we are going to look at the 5 presentations that have been done, which have done a lot of justice to the topics given to them. All the 5 experts have done a wonderful job. And I, for sure, from the side, from the National Neonatology Forum, as well as from the National Collaborative Center for Facility-Based Newborn Care, would like to say that we will take up this quality of care work across the SNCUs along with our regional centers and state centers with the help of Ministry of Health, with the help of AIMS New Delhi and the NHSRC. So basically looking at everybody's support and initially trying this out well iron through the public health institutions, and thereafter this also needs to be taken to some of the corporate private hospitals, and we do have a lot of neonatologists who are working in these areas, in these institutions, and they are taking up the QI initiatives. I'll invite Dr. Ranjan to sum up the session, and then we can hand over back to the WHOCC. Dr. Ranjan, please. Need to unmute yourself. You took the advice very seriously. You have muted yourself.
You have, yeah. We were kindly given 20 extra minutes by Dr. Devarari. I think we are coming to the end of even that grace period. It was a wonderful session. This wonderful session 1 on technical aspects of managing preterm newborns with the theme as do no harm, and all the aspects of newborn care, starting from burden of prematurity, WHO standards, best practice guidelines, clinical practice guideline program of NNF, and QI initiative, all have done justice to the topics given. The speakers have really done justice to the topics allotted to them. We learned a lot. It all were quite crisp and very informative sessions. It is not fair to make the second session wait. So thanking all the speakers once again, and thanking the doctors, nurses, and all the healthcares who have listened to these talks, and hoping that they will take home the messages and implement them as best as they can. I hand over the mic back to the WHOCC office, the hosts, to go on to the second session.
Thank you
Once again, one and all.
Thank you, all the moderators and the speakers for this wonderful session. So thank you all the moderators and the speakers for this wonderful session and finishing well within time. For the next session, highlighting the role of stakeholders in the mother, child and newborn health, I now would like to invite Professor Devarari, President NNF, to deliver a welcome address. He is in charge of WHOCC at AIMS and a pioneer in establishment of quality initiative across the country. Sir.
Thank you, Deepika. So it is my proud privilege to welcome all colleagues who have logged in through YouTube to listen to the deliberations of session 1 and the session 2, which is going to start now. Members from National Neonatal Forum of India, Indian Academy of Pediatrics, Indian Association of Newborn Nursing, Federation of Obstetrics and Gynecology Society of India, FOXY, and many of the families who have joined to listen to what we are discussing today. I am so happy that we have all the most important stakeholders who are going to discuss that we are all together for this important cause to show our commitment that premature babies need special cares, their families need support. As we learned in the session 1, that 1 in 10 babies are born before 37 weeks of gestational age. And what we need is, we need investment in the health system, strengthening of health system for ensuring quality of care to most vulnerable preemies with equity of care and dignity of care. And I am so happy that today we have with us from UNICEF, from World Health Organization, India Country Office, the WR, from Ministry of Health, Dr. Sumita Ghosh, Additional Commissioner of National Health Mission, and Professor Vinod Paul, who would join us very shortly as he had some important meeting at this point of time. So he said as soon as he finishes, he will join back to us to address on this important issue. Over to you, Deepika.
Thank you, sir. So moving forward, now I invite Mr. Luigi D. Equino, Chief of Health, UNICEF, to speak a few words on the Survive to Thrive agenda. UNICEF has been an important partner with Government of India for implementation of various mother, newborn and child health programs in the country. Over to you, sir.
Good afternoon, everyone. I'm hearing some echo. Could you confirm, please, whether I'm audible?
You are
So
audible.
you're audible.
Yes, you are.
Okay, so good afternoon. I seem to have some problems with the video. Apologies for that. First of all, thanks to everyone who delivered and or attended this event so far. And thanks to Professor Diorari, NNF, and all the others for making it happen. The first part was a great lesson for me, and I'm sure for many. I see there are more than 100 participants linked via YouTube. A lot to learn and a lot to reflect on. As we move into the role of stakeholders, I just want to share very few reflections from the UNICEF side. And again, on behalf of UNICEF, thanks to everybody who is a warrior for the health and development of newborns in India and beyond India. I'm sure that most of you, I would challenge any of you actually, to tell me that if it's true or not, that one of the first things you look through the day in the morning is probably what are the latest news on the COVID-19, number of cases, number of fatalities in India and outside India. And we have our COVID warriors across the country. Well, if I look at the numbers of yesterday, India lost 430 lives to COVID-19 in 24 hours. If I look at the statistics of what are the newborn
We are not able to hear you, sir.
I think he has lost the connect.
Yes, sir.
Yeah, but UNICEF
You can
office,
avoid with
Bakul, UNICEF office must have a good stable connection.
yes.
So let me call you.
He's logged out also.
It's on the next one. We'll wait for the.
You're unmuted.
Oh, great. I'm back there now.
Okay. Sure, sir. Please go ahead.
Hello?
Yes, sir, you're audible. Please go ahead.
Okay, sorry, I don't know. I am afraid my line broke. I don't know when.
No problem, sir. No problem.
Okay, so can you just tell me when my line dropped?
I think you were comparing the number of COVID deaths and the
Okay,
newborn
right,
deaths.
perfect. Sorry, apologies for that. Is the joys of these days. So I was saying that the newborn health and survival and development pandemic is 5 times larger if we look at the numbers of today. And it's not about comparing what is best or what is worse. It's about taking stock of the fact that we continue having a huge challenge ahead of us, despite of the amazing gains that India has made in the last decades, which should be recognized and are recognized globally. And trust me, being a foreigner and a non-doctor and a non-neonatologist, in many of the practices when it comes to newborn health and newborn care, the world looks at India. So you should take this proudly and continue being excellent in that regard. So within this context, this is a special week. It's the week where next Friday, 20, is the World Children Day. And that's really about everywhere in the world celebrating children, and in that, celebrating the rights of children, and in that, celebrating the right to life and development for every child, which again speaks to our newborn health agenda. If we look at today, prematurity, for me, on reflection, as I was reflecting on the medical and the non-medical aspects of preterm, really, this speaks largely to an agenda of survive and thrive, which in itself speaks to an agenda of primary health care, or a vision of broad primary health care. From the very concept at the center of the WHO framework for primary health care, which is health and well-being, in the very, very same way, we need to start, and I've seen many of you already referring, not to survival any longer, but to survival and development. The concept is shifting, and in doing that, we need to look through the stage of life, of course, from pre-pregnancy to pregnancy care, and throughout 3 years of the child life. As we do that, I think there are 2 or 3 key points that globally are being looked at. One is look at child survival and development, and in particular the newborns, along a continuum of care from home and community facility and then secondary hospitals. So that is certainly one aspect that we need to continue looking at throughout. The second is to look at it with a multisectoral angle. This agenda to work needs to go beyond clinical care, because there's more than that in an agenda of newborn survival, in an agenda of preventing stillbirths, in an agenda of preventing preterm babies. We need to look at how and where and at what point other sectors, be it education, be it nutrition, be it protection, need to come in to support the same gains. The third point, central, and many of you have referred to it before, is about educating and empowering families. At the end of the day, the families are at the center of the whole period of pregnancy and then delivery and then post-pregnancy, and they need to have the right education and the right knowledge to adopt healthy behaviors and to take action when required. In this scenario, I think looking at from a perspective of one of the partners contributing to this agenda, a few actions where from the UNICEF side, we would like to call your attention to. First of all, policy. I think the Ministry of Health, Dr. Sumita, yeah, she's online, Ministry of Health and has agreed to embark on a review of the India Every Newborn Action Plan at the earliest. And this is really, and thanks Dr. Ghosh and the ministry team for that, this is really a unique opportunity for stock taking. What have we done well, what not, what needs changing? Second, practices. I've heard a lot of QI and quality improvement and standards and approaches, and also about proven practices. Now, these practices need to be replicated and cascaded down. Implementing a perfect model in a limited number of facilities will not be sufficient any longer. We have learned this year how we can use online training, online mentoring, even online supervision. So let's cascade these practices down to those facilities where they're not yet implemented, and let's do it quickly. Three, existing platforms. I will borrow a concept that I've learned from Dr. Paul, and it's a very true concept. If you look through the 1,000 days, the government of India has put all the programs in place. For every stage throughout the life course of the 1,000 days, there are practices and programs and initiatives. My plea to this group today, amongst the many, as we work on quality, please let us also not forget the critical importance of home-based young child care and of home-based newborn care. These are amazingly well-designed programs. The scale is not yet where it needs to be. Let us please work together to bring these to the maximum scale we can. They are essential and absolutely necessary to complement the work at facility level for child survival and child development, survive and thrive. Another point I want to make is about healthcare health workforce. It has been again said in the previous sessions. One point of attention from our side is collectively supporting the initiative of the Ministry of Health in scaling up the new midwifery cadre across India. It is a massive game changer, big investment, absolutely difficult in these times of COVID-19, but something that we need to look at to further sustain and amplify the gains. Very last 2 points from me, and then I'll close it. One other point on where we can quickly bank on a number of things that have come through COVID. If today we look at COVID-19, IPC, infection prevention and control, has become the largest agenda globally. In that, we have a lot to do still when it comes to Laksha, when it comes to SNCUs. There's a lot of improvement to be done. So let us bank on the knowledge, on the resources, on the momentum, and improve IPC practices also for maternal and neonatal care. Same, and I'm referring to a Lancet commentary from Dr. Tedros and from our executive director, Henrietta Fore, of earlier this week, just published. There is massive investment across the globe and in India as well on oxygen, system strengthening for oxygen. Let us use this opportunity that COVID is giving us to bank on it and make this oxygen also work and make it available for whatever and wherever is needed for maternal and newborn care. Essential, and again, these are low-hanging fruits that the tragedy of COVID-19 is bringing to the health sector. Let us try to use them. The very last, data. We have data. We are, I suspect, and I fear, and I'm afraid to state that we are not yet using data as much as we can at the level of granularity we should to track where the newborns are and when the bottlenecks are and to address them in real time. And in that, again, we have unique assets. SNCU Online is unique in the world, or nearly so. HMIS is being revamped. Let's overlay these data sets and try to use them for granular tracking of children at sub-district block level and below. That's the only way we can track what's happening to children after they leave the healthcare facilities and follow up. This is it from my side. Just to close it, although this year is a year of virtual meeting, virtually our doors remain open to everyone, every partner, every stakeholder, be it in Delhi, be it in the field offices, be it in the aspirational districts where we have colleagues supporting the agenda. Please come and see us. If you have ideas, we are happy to support as much as we can and to the best we can. Thanks a lot again to all the partners, to Prof. Diorari for organizing this, and to the Ministry of Health, my last thank for continuing pushing the newborn health agenda in the middle of an incredibly unique situation. This has been an amazing effort, and I hope it will have to protect the gains going forward. Over from me. Thanks.
Messages for Survive to Thrive agenda for the day. So next I invite India country representative of WHO, Dr. Roderico Offrin. Sir, you there?
Yes, sir.
Oh, okay. So I invite Dr. Offrin to share his views on global guidelines for strengthening the health systems and operational guidelines by the WHO headquarters pertaining to the maternal and newborn health.
Over to you.
Over to you, sir.
Thank you very much. Thank you for the invitation. And good afternoon, Professor Pino, Dr. Sunita Goro, from whom we just heard from Professor Deragi, Dr. Kulparek, Dr. Alpesh Gandhi, Dr. Jyoti Savin, distinguished guests from the ministry, professional associations, doctors, nursing colleagues, and representatives from partner organizations. Good afternoon. I am very delighted to be here this afternoon that we are looking at a health issue that's at least non-COVID, or we can call non-COVID, and it is a national event on World Prematurity Day. This is a key moment to increase awareness and engage with all partners about the issues of preterm birth
preterm survival and their optimal development. I would like to congratulate the government, the National Neonatology Forum, and all stakeholders present today for placing health of newborns, especially that of preterms, high on the country's health agenda. Their well-being determines the health of families, the health of communities, and the human capital of the nation. We have to look forward to this in terms of reviewing it as a problem, not just something for operationally or clinically, but it is a public health problem. As Luigi said, I'm not a neonatologist or pediatrician, but just to give you the number, it is 2.7 million preterm babies in India every year. And as we have all been mentioning and discussing, addressing this public health agenda is a collaborative effort. Today, I will just speak on the importance of guidelines. Maybe people are just saying, okay, what's the use of a guideline? We have heard several speakers already saying that it is important. It is the basis of good practice. It is the basis of how, if implemented well, will save lives. So I'll be discussing a few of the global strategies and then to note what India has done, and because it's a very commendable achievement. And as we all know, India, the world looks to India for many of these achievements, especially in this area. At the global level, we have the Global Strategy for Women's, Children's, and Adolescent Health, the 5-year operational framework, as well as the technical resources that have been developed to support country-led implementation. This global strategy takes a life course approach, so it's not a one-off. So it's from antenatal services to delivery to the next 1,000 days, even to adolescent health, till women's health as elderly. That a person's health at each stage of life affects health at other stages. That's very important to know. There is already evidence that the status of a mother affects how the child will be in the future, even their NCDs. It has cumulative effects for the next generation. Data from across countries show that low socioeconomic and educational status, low maternal age, as less than 17 years of age, and the low pregnancy body mass index are some of the maternal demographic characteristics associated with preterm births. As mentioned by my colleague from UNICEF, it is not just the health sector, it is beyond. These are issues of society development and culture and really looking at how we'll be able to change unhealthy practices. In terms of for the global health strategy, it really adopts an integrated and multi-sectoral approach, recognizing that health-enhancing factors, including nutrition, education, water, clean air, sanitation, hygiene, and infrastructure are essential to achieving these goals. Not one is any less important. Everyone's role is so important. In this, every health indicator and addressing every risk factor is important. This vision is well reflected in the government of India's commitment to invest across the life course. Through the Reproductive Maternal, Newborn, Child, Adolescent Health and Nutrition Program. The India Strategy for Women, Adolescent and Child Health, launched in December 2018, defines this global vision and has contributed to decisively move the policy and the program agenda forward. Investments across related sectors, including Poshan Abhiyan, Swachh Bharat Mission, Sarva Shiksha Abhiyan, along with Rashtriya Kishore Swasthya Karyakram, addresses several of the underlying causes associated with preterm birth and is quite comprehensive and visionary. As mentioned, there is a program for every throughout the course of 1,000 days. No country probably has been able to kind of do this. And again, these programs are also across sectors. 2, another global initiative where we have a strong India adaptation is the Every Newborn Action Plan, launched in 2014. It is a comprehensive multi-partner initiative to improve access to services and the quality of care. The previous session was talking a lot about improving quality of care. India was amongst the first few countries to develop the India Newborn Action Plan. Again, as we are mentioning, India is a global leader. Setting out recommendations on reducing newborn mortality and stillbirths and to close gaps in equity accompanied by specific goals, coverage targets, and milestones. Globally, new coverage targets and milestones for Every Newborn Action Plan for the period 2020 to 2025 were recently launched in September 2020. And I understand that India plans to review and revise the Indian Newborn Action Plan and roadmap for 2030 against these new targets and milestones. So it's really important that the national plans, policies, and programs keep being reviewed and improved. That's the only way we can collectively learn together and target this, well, at least for today, what we're talking about, the 2.7 returns we see already. At the regional level, the strategic framework for action for newborn and child health and development for the Southeast Asia region of WHO, which was published in 2018, has provided guidance to member states on accelerating action during the next 5 years to further reduce newborn and under 5 mortality, achieving SDG 2030 targets. That's a global target that we are all contributing to. And India has a huge role to play in achieving such a global target. Given the national burden of preterm birth, the next important step is also to make greater investments. That has already started in the country, but it's really looking at improving the quality of care for all pregnant women and preterm newborns. In September 2020, as mentioned, WHO has launched the standards for improving the quality of care for small and sick newborns in health facilities. So that's something that we need to build on. It's standards that build on essential newborn care and ensure consistency with the WHO quality of care framework. Collectively, it's all of us. It's on all of us as public health professionals, as neonatologists, as pediatricians, as hospital administrators, as health system leaders, subnational health authorities. It's on us to champion the cause of newborns and practice and advocate to refer to these standards and guidelines to help plan and deliver ensure quality of healthcare services in newborn care facilities. I know that there's too many standards and you cannot achieve this all at once, but discussions can start now. It is the basis for good practice and to save lives. How best do we integrate them to our system based on a facility or clinical practice assessment, but also in terms of engaging communities and families that there is this available service for newborns. Lastly, probably the area of focus of leadership at all levels. We already mentioned and commend the work of the government of India. In fact, it is one of the 2 vice chairs of the board of the Partnership for Maternal, Newborn, and Child Health. This is the world's largest alliance for women's, children's, and adolescents' health, bringing together partner organizations across 192 countries. Equally important, apart from government leadership, is also leadership by professional associations, doctors, nurses, neonatal health experts, represented today by professional associations, the NNF, IANN, IAP, and FOGSI. As you know, the global theme of the World Prematurity Day is Together for Babies Born Too Soon, Caring for the Future. I know the national theme is also Do No Harm. By doing no harm, we're caring for the future. Therefore, I am encouraged by the presence of so many partners in this platform and so many discussions and knowledge sharing. This reiterates that collaboration and partnerships are key to make further progress. We at WHO, along with UNICEF, are committed to providing the technical support required in these ongoing efforts. It keeps changing. As you know, our context keeps changing. We are working with partners also to conduct research into the causes of preterm birth and testing effectiveness and delivery approaches for intervention to prevent preterm birth. Even at this context of COVID, we are looking at research of pregnancy outcomes in the context of COVID with several WHO collaborating centers. And I think that's the last point. In this challenging time, it's not to focus everything to COVID response. That period has already gone, but it is also not to overlook that there are essential health services. Back to the number, there are 2.7 million preterm births this year, COVID or no COVID. And even with COVID, need that attention. I sincerely hope that together we identify and agree upon new opportunities for longer-term collaboration and make sure that every provider, whether a pediatrician, obstetrician, a neonatal nurse, community health worker, takes accountability both for maternal and newborn health outcomes. Before I close, I would like to take the opportunity to thank each one of you for the wonderful work you're all doing as part of the pandemic response and in ensuring that essential health services are being rendered to all mothers and newborns who need them the most. Stay safe and stay healthy. As we always say, I always say, take care of yourselves so you can take care of others and take care of those who take care of us. Thank you.
Thank you, Dr. Afrin, for the words on global guidelines. Steering the session further, I would like to invite now Dr. Sumita Ghosh. She is the Deputy Commissioner for Maternal Health in the Ministry of Health and Family Welfare, Government of India. And National Health Mission has established more than 800 SNCUs in the country and also has strengthened many, many medical colleges across the country. So over to you, ma'am.
Thank you. Good afternoon, namaskar. I congratulate NNF, National Neonatology Forum, WHO, for organizing this, especially in the National Newborn Week, which is going on now, and also on the World Prematurity Day. So these are the focus areas. The Government of India has made strategic investments in this area. So the discussions and deliberations which are happening today is very, very much warranted. And all the stakeholders are here together. I'm greetings to them from MOHFW, who are stalwarts, who are working in this field, and whose participation and active cooperation is needed if Ministry of Health and Family Welfare is aiming to attain the SDG goals and the INAP goals. With this brief introduction, I would say that the National Newborn Week, which is till 21st, from 15 to 21st, this year the theme we have decided is ensuring quality, equity, and dignity for the newborn care at every health facility and everywhere, beyond the facility also in the communities at home. So these are the targets, these are the themes which we must carry forward as in this neonatal week, National Neonatal Week. I would say that the investments and the strategies which the government has adopted will not be successful if all the stakeholders are not together. There are, as neonatal health, we all know who are in neonatology, we are working with the neonates. The neonates being vulnerable, fragile, as well as the care. It requires, skills, knowledge, attitudes of the highest order. So this being the case,
ensuring the quality, the equity, the dignity at all facilities and communities and home care. It should have the involvement of all of us stakeholders who are present here today, all our partners, all the professional organizations, the nursing fraternity, and the specialists, as well as the general practitioners who are there, who are taking care of the newborns. If we look, I think much has been discussed in this forum now today on the quality, on equity, on the scenario. So I won't get into too much into it. We have achieved certain milestones here. We have achieved the INAP goal, which was there for 2017, which was 24 NMR. We have achieved that, but in order to achieve the single digit goal by 2030 of the INAP, and also the SDG goal of 12, there is a lot of grounds to be covered now. Here comes the question of quality and equity. If we look at the equity, many states, they have already achieved the SDG goals. 3 states have achieved the SDG goals, and 8 of the states have achieved the national health policy goal, which was 16 per 1,000 live births. But there are states which are there. There are areas, especially our aspirational districts, which are way behind. So it is now the time to reframe our strategies and look at these areas where we need to achieve much, much more. When we look at the various initiatives which I'm supposed to talk about, we have taken a life cycle approach, because we know neonatal health depends, it starts much before the baby is born. It is in the preconceptional stage also, where young mothers, adolescent pregnancies, they suffer a lot. Then in the conception period, when the ANC checkups, the regular high risk managements, they contribute a lot. Then the intrapartum period, which is the maximum impact, is there. Almost 40% the mortality is varying around that period. Then comes the essential care. Then comes the care of the sick and small newborns, which the previous session dealt with. And beyond that also, beyond the neonatal period also, because survival, once we get into the survival, the children, newborn survive, then comes the question of thriving the after the neonatal period. A lot of the quality aspects will look into that, because even if the neonate survives by the aggressive management, we have to be very careful about the quality, because the life beyond the neonatal period will depend a lot on the quality of care, because beyond survival, the development aspects, the delays, the intellectual developments, the musculoskeletal developments, the various effects will persist if we don't look at the quality, and it will persist for the rest of the life. So here comes another aspects, that beyond mortality, we have to look into the morbidity aspect also. So INAP strategy was adopted, one of the most early countries to adopt the INAP strategy in 2014. There is a mid-term review which is happening. We have reviewed the progress we have made. The 6 pillars which are there, we have made progress into many of them by various kind of high impact evidence-based interventions. I'll talk very briefly about it. When we talk about the facility-based newborn care. We have a level tiered system, which is at all delivery points, the newborn care corners are there, and at FRU level, we have newborn stabilization units. We have approximately now around 2,500 plus units in this stabilization unit at the FRU level, so that this neonates which are not that sick, they can be managed at these facilities nearer to home and prevent the overburdening of the system at the SNCUs. Then comes the special newborn care for small and sick, which we are happy to say almost 80% of our districts, they have these SNCUs right now. We have around 894 as functional SNCUs in the country, as well as these SNCUs are not only functioning well, they are providing online data for real-time monitoring as well as evidence generation, what is working, what is not working. Beyond facility-based intervention, because that is the most important interventions for prevention of mortality and morbidity, we have several other initiatives spanning over the pre-conception, conception, and post-natal period. A few of them I will say that we all know: the Janani Suraksha Yojana, Janani and Sishu Shastra Karyakram, JSSK. They are these interventions. They promote institutional birth and free and quality services to mothers as well as newborns till 1 year. We have HBNC, home-based neonatal care program, and HBYC program. We have several antenatal interventions, Pradhan Mantri Suraksha Matritya Abhiyan. We have the quality certification of high delivery load points, that is Lakshya certification. Till now, 500 units have been certified under that. I heard midwifery training is being mentioned. We have identified institutes all over the country for midwifery training, which again I think is a it will turn out to be a very effective intervention for mother as well as the neonates. Then nutritional interventions are there. We have MA program for exclusive breastfeeding. We have, in unfortunate cases of lactational failure, we have established CLMC, comprehensive lactational management units, as well as LMU, lactational management units. Apart from that, various other initiatives are there, community-based initiatives like village health and nutrition days. Our HBNC program is catering to 1.42 crore newborns annually. Last year figure I am quoting. So again, beyond the facility intrapartum period, there are interventions, which is the SARS program. Pneumonia is again one of the very important cause. We have beyond neonatal period RBSK programs to look after the birth defects, the disabilities, the delays, the deficiencies. We have 11,500 mobile units which are looking, which are screening the neonates, screening the children, because are for thrival of them, so that they grow and develop well. The DIC management are there when these children who are being identified with these 4 days, they are referred to these DICs for effective management. We have birth defect surveillance program, early childhood development program, which is a very important program, which looks into the the conception period, from the first day of conception to second birthday, so 1,000 days. Various programs are addressing this. The major flagship program for neonates and beyond, we have MCP card issued to all mothers, so that these neonates and children can be followed up afterwards. And we have immunization program. So this array of programs which are presently Government of India is having, we have made the progress, no doubt, but taking it beyond, again, I emphasize that we need all the partners together, all our development partners, as well as our the professional bodies, the specialist bodies which are with us today. We have the set up the National Collaborative Center, and then at the regional level we have regional resource center, we have state level resource centers, and now we are planning district level training centers. So these are all we are doing for ensuring the quality, equity, and dignity part, I would say we have certain evidence based programs introduced. One of them is family participatory care, and another is having the mother together with the sick baby at the SNCUs, that is MNCU program, the mother and neonatal care unit, where they are both together and the mother supports in the care of the newborn. So with this brief about the programs which government is having, what are our expectations from our these professional bodies, from the private doctors, the specialists who are present today? I believe the apart from service delivery, which again is the most important factor, I must say, there are much bigger roles that can be played by them in capacity building of the doctors in neonatal care, for their mentoring, for guiding them, for generating evidence and sharing them with us, for so that best practices can be adopted by the ministry, for having data and for monitoring the private as well as the the apart we have data for the public sector, but private is again a huge sector. We need data from there. We need the support for having their facilities, the private facilities certified, and for provision of quality care, and for strengthening of both the private as well as the public sector. So with these few words, I would say that neonates, though they are small, they are vulnerable, but they have tremendous capacity to, fight back in case of asphyxia, and in case of any illness. My professor would always say that for a neonatologist, it is very important to think that, to believe that jab tak swaas hai tab tak aas hai. They can suddenly one almost pale blue baby can suddenly come back into the pink of health with just one cry. So taking this attitude in mind, and also believing that as a neonatologist we need perseverance, and also nursing, have the nurses who are attending the neonatology units, perseverance, tenacity, resolution, commitment, dedication, and a never say die spirit is very important, both for the program as well as for treating individual neonates. Thank you very much for this patient hearing.
Thank you, ma'am. So now I hand over to Professor Durari for further sharing of the session for today. Over to you, sir.
Thank you, Deepika. So I think it has been wonderful listening to all the important stakeholders from UNICEF, WHO, India Country Office, and finally from Ministry of Health. What excellent work they are doing, taking everyone together. And then listening to the advices from both UNICEF and WHO, improvement of premature care is a multi-sectorial approach. It needs investment in the health system. It needs, in addition, healthcare professionals and the families who have to work together to make sure the babies not only survive, but they thrive well once they go home. And then linking facility-based care to home-based care, so important. So community care is an equal important aspect of providing care to premature babies. We don't want our premature babies to be malnourished, stunted during first 5 years of life due to malnutrition, because it is again going to increase the burden due to deaths due to pneumonia and diarrhea. And as rightly pointed out by Dr. Sumita Ghosh, that it is so important for all of us that all the professional organizations are on board for taking this forward, because without obstetrician and FOXY people joining in this endeavor and the nurses joining in this endeavor with Indian Academy of Pediatrics, who work at grassroots for making sure each and every newborn babies, whether term or preterm, gets the resuscitation and essential newborn care. We have all these stakeholders who are very important for us for making sure that our babies survive, they thrive, and there is equity of care with dignity which is provided to these preterm babies. So may I ask now all the stakeholders from Indian Academy of Pediatrics, FOXY, Indian Association of Newborn Nurses, and most important, we have one of the mothers, Megha, who had a baby who was born preterm in a hospital, to tell us a little bit about her experience, and then we will take inputs from all the professional organization presidents onto how they will support that preterm babies survive and thrive well, and we are able to provide them quality care with dignity. So may I ask Anu to give a link to Megha. She is the mother of baby Pratibha. She will tell us her experience while she had to take care of her baby in the NICU. She will speak for 3-4 minutes, and then we will give it to the important stakeholders. Vinod Paul is about to join, and he will address all of us at the end of the session. So may I ask Megha? Megha?
Thank you, sir,
Yeah.
for giving me such opportunity to
आप
share my
मेगा आप हिंदी में भी बोल सकते हैं, हिंदी में भी बोल सकते हैं.
me in care of my we premature. God grace and just grew up this baby. She's now 5 years old. She's fit and fine. And I want to just let me share my experience, which I learned from doctors. Supportive family and involvement of family is must. Proper health and hygiene of the mother and baby. We need to just take care about that. And husband role is must with mother to take care of his baby also. Follow doctor and nurse staff instructions from whole heart. Keep baby warm with proper clothing. Give KMC to child as much as possible. We can take help from the family if you are not able to give more than 2 hours KMC. He measures measure of your measure out your weight and baby's weight and her height.
take regular feedback from doctor and take care of your baby as doctor instructions. Always be with your baby in a happy mood, because when you are sad, then baby get also sad, even though he can't speak, but he can feel your feelings. Proper diet of mother is must, and we should give them medicine on time. That will help out about it to taking out from their weakness of bodies. Thank you.
Thank you. Thank you, Megha, and good to see Pratibha. She's 5-year-old. She was born preterm with a weight of 1 kg and stayed in the hospital, went home, and parents have taken care of the child quite well. So now let me ask my brother, President of Indian Academy of Pediatrics, Bakul Parekh, to say a few words how Indian Academy of Pediatrics can contribute in taking this agenda and the journey for premature babies in the country forward. Over to you, Bakul.
Dr. Hari sir, for giving this opportunity for me being with all these luminaries on this platform. Let me tell you that IAP has been very active and in forefront with a focus on this year's theme, that is together for babies born too soon, caring for the future. So IAP is definitely committed to the care of preterm, and it encompasses several layers of care, which I will like to elaborate. IAP has been involved and continues to be at the forefront in the art and science of preterm care, which is evidence-based practice, imparting knowledge, disseminating skills, empowering pediatricians to care for the preterm. As you know, that IAP NRP FGM project, in partnership with several other professional organizations, we are involved in teaching and training of basic newborn resuscitation and newborn care to all the practicing pediatricians at grassroots level. And the aim of this particular program was to create 2 lakh birth attendants in 5 years. Probably it includes trainers as well as providers. And the ultimate objective was to have a person who is trained in newborn resuscitation and care is present in every delivery at the time of neonatal resuscitation and neonatal birth. And I'm sure we have achieved this target to a great extent. And it has been continued all throughout these years, and it will continue in future also. Also, IAP through its neonatology chapter provides country's largest subspecialty teaching training program, which is spread across 100 plus centers across India. It is not only survival, but the intake survival which matters. And 90% of the newborns don't need resuscitation, 10% need only some resuscitation, and 1% needs advanced resuscitation. But preterms are at more risk. They need special precautions to prevent brain injury right from the labor room. And for this, we know that the brain is the development of the brain is the most critical period is 26 to 40 weeks when your cerebral hemisphere and cerebellum develop. And also the myelination occurs. So damage during this vulnerable period of developmental care can cause preterm encephalopathy and all sorts of morbidity. So all our preterms need to have long-term follow-up also. And IAP has provided growth chart, IAP growth app, which are provided free to one and all for ensuring the growth of all our babies and which are being monitored. Early detection and intervention for malnutrition is another key factor. So nutrition during first 1,000 days are very important. And we are following IYFC guidelines. Our IYFC chapter is very active in promoting breastfeeding for the first 6 months when it is taken as the optimum nutrition which is required. But After 6 months, we always insist on home-based, culturally appropriate, complementary feeding along with ongoing breastfeeding to ensure the optimal growth. IAP also has come out with a policy statement in complementary feeding. Also, stimulating the preterm brain is very essential. And through its experts, IAP has recently come out with a consensus statement on early stimulation to promote the bright start to all our newborns, including the preterms. We have also started concentrating and focusing on the early childhood development by giving lots of efforts on first 1,000 days nutrition, as well as immunization, and also early detection of all the abnormalities, even though they may be subtle, and provide early intervention services. Also, we are promoting KMC, Kangaroo Mother Care, which is supposed to be the most appropriate intervention, and it is always giving good follow-up, which is otherwise a very weak factor in our preterm follow-up. So because of Kangaroo Mother Care, we are getting lots of follow-up, and then we can have definitely structured follow-up for all these high-risk babies. Scheduled vaccination can be done during that time. Screening for vision, hearing, and motor and mental milestones are done, and then can then be a prompt referral if really required. We are also supporting families during these difficult times, both during and after hospital stay. IAP is currently in the process of compiling guidelines for the parents, and they are also going to come out with a booklet for the care of preterm and newborn and low birth weight babies, which will be also translated in 12 different local languages for it to be useful to different populations. We are also strengthening our healthcare systems. IAP is committed to provide technical support, have partnership with government and NGOs, professional bodies in implementing and strengthening the healthcare system, both in private as well as public sector. Office practice modules, implementation of various guidelines of IAP, guidelines for hospital setup, ensuring and getting to the frontline work, and providing the very best to each and every child in an equitable and dignified manner for every newborn and preterm. Also, we are cooperating with RBA of government, where pediatricians are trained to pick up the developmental defects, delays, and all the red flag signs, and thereby provide proper newborn care. I think with all these efforts, IAP is always committed and ready to work with NNF, NGOs, Niti Aayog, and so many other associations to reach our target and our aim of providing quality care to all the preterms and newborn. Thank you very much, sir.
So, thank you, Dr. Bakul. Indian Academy of Pediatrics is a very important stakeholder. They have more than 26,000 members who are working the level of the districts and below. And as we heard from Dr. Bakul, they are doing a great work and trying to promote majority of the programs of Government of India. Now, newborn babies who are born without good maternal care and intrapartum care, it is not possible that we will have good preterm babies in which good delivery room care can be provided by pediatrician. So it's a very important role the obstetricians play. So we have, I have the pleasure that we have the president of FOXY, Dr. Alpesh Gandhi, to say few words how obstetricians can work together for taking the premature baby care with quality, equity, and dignity. Over to you, Alpesh.
Can I do slide sharing from here? Hello, Dr. Ashok, can I do slide sharing from here?
I think WHO technical team can guide you.
Because it is not available from here. Usually it is there, but today it is. Anyway. Okay, now it is available. A very good evening to all of you, and at the outset, I am thankful to NNF, WHO for this excellent initiative and Today it's World Premature Day, Baby Day, and this type of activities and this type of webinar are really very helpful. I am thankful to all of you for inviting Foxy. I will speak on Foxy's activity and Foxy's vision on preterm labor. I think we have major role in prevention and communication with the neonatologists and pediatricians. Theme for this year of Foxy is safety first for Indian women and Foxians. And in Indian women, already our tiny patients neonates are included. So we want to take care of Indian women, Indian mothers, and our tiny patients neonates. As we all know that more than 1 in 10 babies born early labor before 37 weeks of gestational age is considered preterm labor, and in the world about more than 15 million preterm births are there, which contributes to more than 1 million neonatal deaths. But the unfortunately sad part is India is having the highest number of preterm births, 3.5 million a year, and that is why this type of activity, this type of webinar are very important, and our role as obstetrician and neonatologists and pediatricians are very important. Preterm labor is a major public health problem. It accounts for 43.7% of all neonatal deaths. Prevalence is about 21% of all births and up to 13% of live births. Incidence is increasing with potential for significant short and long-term morbidity and mortality. Across the world, surprisingly, incidence of preterm birth is increasing. And there is also morbidity, short-term and long-term in survivors like retinopathy of prematurity, neurodevelopment problems, hypothermia, or ventricular hemorrhage. Many other complications can occur. Jaundice, many things can happen. All efforts must be made to prevent not just early preterm deliveries before 34 weeks, but also late preterm births, and to avoid iatrogenic prematurity unless strong obstetrical indications are present. It also causes great economical burden to the and to our country, and we all know that major causes.
Alpesh, we have 3 minutes more for you because we have 2 more stakeholders and Vinod Paul's address which has to follow. Alpesh.
Yes. So we know all these causes, but we should also target on these useful predictors. We guide our members to look after these high risk factors and predictors: previous history of preterm delivery, presence of risk factor, and transvaginal cervical assessment. And these are the risk factors: previous history of preterm birth, cervical incompetence, uterine anomaly, genitourinary infection, history of smoking, tobacco. So these are multiple pregnancies. So when we come across such type of patient, we should become very much careful. And when cervical length is more or less than 25 millimeter, again this is high risk patient. So during sonography has made prediction and diagnosis easy by seeing shortening of the cervix and also the herniation of the membrane. And of course, we have our perinatology committee, which is looking after all these things. We are also doing work for the organizing drill for the neonatal resuscitation protocols, and we have our own guidelines also. We are working for the social programs to educate patients regarding impact of prematurity on the neonates, preventive measures, and social programs on social media. And particularly in this COVID-19 time, we all know that the incidence has increased. It has reached more than 20% in many parts of the world, and we particularly are interesting. We suggest this is very important period, pre-conceptional counseling. This gives us important opportunity. It's a window during which period we can counsel with the parents. We can identify the risk factors. Suppose patient is having severe anemia, we can treat. Suppose patient is having folic acid deficiency, we can treat. Suppose patient is having HIV, we can do vaccinations. So many things. This is a period: genetic counseling, vaccination, HIV identification, genetic disorders. We can identify so many things during pre-conceptional period. And on 23 November and 21st November, we have organized a very big program on International Perinatology Conference, where we have public forum and involvement of gynecologists, neonatologists, parents, everything are planned on this day. Particularly, we wish there are three types of intervention: primary aim for all women, secondary aimed at eliminating or reducing risk in women with previous preterm birth, and tertiary aimed at preterm births. And Foxy believes in strong, impactful, respectful partnership. We are working with IAP, we are working with Neonatology Forum, and we last year also we had very useful Sath workshops with pediatricians and obstetricians. And this year also we have worked together and came out with this very, very useful GCPR on perinatal and neonatal management. So we believe that uterus is the best incubator. Each day gained increases the chances of survival. Uterus is the best transporter also, and they should not only survive, they should also thrive. And thank you very much for the patient hearing. And we are there to work together with WHO, with UNICEF, with Neonatology Forum, with Government of India, with IAP. We believe in partnership, and thank you very much for the patient hearing. Thank you.
Thank you, Alpesh. Thank you, Alpesh. So now we have two more stakeholders who have to speak. We know that preterm babies are cared by the nurses 24/7 while they are admitted in the facility. So I have the pleasure in inviting Dr. Jyoti Sareen. She is the president of Indian Association of Newborn Nurses, to kindly speak for next 3 minutes on role of nurses, how they can contribute in improving outcomes for premature babies. Jyoti.
Good evening, sir. And I extend a heartfelt gratitude to National Neonatology Forum for involving Indian Association of Neonatal Nurses to be a partner in this endeavor. Indian Association of Neonatal Nurses remains committed to support implementation of quality initiatives and dissemination of its outcomes as a part of broader approach to improve intact survival of premature neonates. As all of us know that neonatal nurses have been actively engaged across the country as the key member of QI teams to improve and implement evidence-based nursing practices, such as encouraging the use of mother's own milk as first feed for preterm and very low birth weight neonates admitted to NICU. Next is quality improvement initiatives to improve the screening rate of ROP in outborn neonatal intensive care, reducing hypothermia in newborn admitted to neonatal care units. These are few examples, but in all the QI projects, the neonatal nurses are taking the key lead and are able to disseminate the quality initiatives to others. And evidences have shown that the centrality of the neonatal nurse's role in preventing hypothermia, facilitating KMC, promoting breastfeeding, enhancing maternal-infant bonding, empowering parents, and in reducing the risk of nosocomial infection and neonatal nurses. Neonatal nurses have a pivotal role in humanizing and implementation of family-centered developmental supportive care for preterm neonates in facility as well as in community, and utilizing the research into practice. INN, as a national professional association, has an important and collaborative role to play in updating the teaching learning material and carrying out activities to support safe and effective implementation of evidence-based practices through annual conference and continuing education program. Then, responding to the need to prepare specialist nurses in India, INC has planned to design post-basic diploma clinical residency program utilizing competency-based training approach, where the theory component is only 10% and practicum is 90%. And it is focusing on adult learning principle and experiential learning and self-directed learning. The curriculum has already been prepared and submitted to INC and looking forward for its approval. Then INN is also in the process of developing standards for neonatal nursing. And as everyone is aware that the preterm care app as well as facility-based newborn care module has been widely disseminated and integrated in the pre-service nursing education. Where we find the gap is on hands-on. So for that, recently we have planned to develop an online skill-based learning program for the neonatal nurses for in-service as well as the pre-service training program. Then INN is working in close association with NQOCN on newborn week activities as well as Ministry of Health. Then even we have designed a webinar series for 3 consecutive days during this time so that we are able to reach out to our maximum in-service nurses and pre-service nurses. Of course, we need to focus on developing a pool of trainers. That is the prime activity which we need to focus upon. And as well as we have to now diverse ourselves also towards the ASHA workers and towards ANM upliftment. So these are the future vision where we have to take care of because already they have a lot of curriculum is there for ANMs, but their hands-on and their thing, if we are able to contribute, we'll be very happy in that. So again, I reiterate the commitment of INN for implementation of quality initiatives for the improvement in the survival rate of premature babies. Thank you.
Thank you, Jyoti Sareen. I think it brings in importance of newborn nurses who are specialist nurses who take care of these babies. So maybe in times to come, in years ahead, we need to have neonatal nurse practitioner type of courses which have to be done by accredited units all across the country, because nurses will be able to take care of even sick newborn babies in the SNCUs which are at remote places. Now, we have the last stakeholder, which is NNF. So I'm requesting my Secretary General to speak for next 3 minutes. And following that, Vinod Paul will be talking.
Thank you. Respected dignitaries on the platform. Am I audible? My dear friends, colleagues, nursing officer, good evening, festive and newborn week greetings from NNF. Our organization came into existence in 1980 through the initiative of a handful of leading pediatricians working in the field of neonatology. And I'm happy to share that today we are a family of more than 8,000 members consisting of pediatricians, neonatologists, obstetricians, and most important, the nurses. NNF has been networking with partners and stakeholders like Government of India, state government, FOXI, IAP to improve newborn care in the country. Preterm has been a big challenge in achieving the targeted NMR. In past 2 decades, there has been a remarkable progress in the survival of mother and children beyond neonatal period. Newborn survival, especially the intact survival of preterm, has lagged behind. To bring down NMR to single digit, we need to prioritize the health of preterm infants, a major contributor of neonatal death. Hence, the stakeholders, professional bodies, Government of India need to gear up to address these problems in a way which is affordable, available, and doable. NNF is committed for advocacy, a scaling up of low-cost, high-effective intervention like essential newborn care and resuscitation at birth, and early exclusive breastfeeding, care of preterm and LBW, including KMC, maintaining temperature, prevention of sepsis. Under the able guidance of our pragmatic president, Professor Devrari, we at Central NNF have been doing a lots of online activities during this challenging time of COVID-19 pandemic for intact survival of preterm. Preterm care capacity building is spreading through a series of online courses on preterm care. We have also developed apps for preterm care package. NNF has a flagship program of accreditation in place to maintain a standard of care for sick and preterm baby. We have more than 200 accredited centers providing quality of newborn care. We have a fellowship program for capacity building of both doctors and nurses to create next generation of neonatologists and neonatal nurses. We have trained around 700 neonatologists and 500 nurses in this regard. To empower and facilitate the frontline newborn care provider, the nurses, we had launched a preterm care course for nursing staff on Telegram platform. And around 5,000 nurses and 70 faculty across the globe have been participating in this mission. NNF have been involved in spreading low-cost, high-impact KMC for preterm and LBW infants in SNCUs and medical colleges. NNF ensures that preterm babies thrive well by promoting exclusive breastfeeding and IYCF program to prevent malnutrition and stunting. NNF has developed clinical practice guidelines for preterm care. As Dr. Praveen has explained, like we have ROP screening, oxygen therapy, which have been widely accepted and used in management of preterm. NNF is at forefront along with the families of preterm infants to ensure quality care with equity and dignity. So friends, on this World Prematurity Day, may I call upon all our colleagues, stakeholders to come together for ensuring intact survival and care of preterm infants. So with this, thank you all.
So, thank you, Lalan. Thank you, Lalan. Please mute yourself. Okay, so I think as we are approaching the end of the program, I have the great privilege in inviting Professor Vinod Paul, who is member Niti Aayog. Everyone knows Vinod. He is equated with improving newborn health in the country. And he was in the forefront while India, for the first time, made an advocacy document, Key to Newborn Survival, 20 years ago, which was unveiled by our late Prime Minister, Shri Atal Bihari Vajpayee. Vinod was instrumental in making advocacy and policy documents for state of newborn health in India and the INF document, which was released in 2014. And at this point of time, he all know that how he is connected with the Ayushman Bharat initiative of Government of India and Poshan Abhiyan initiative, which embraces universal health care for equity of care, cost-effective care with quality, which has to be given to all mother and all newborn babies in the country. So may I request Vinod Paul to give his keynote address. Vinod, over to you.
Thank you very much, Ashok. Can you confirm that I am audible?
Vinod, you are audible.
Am I audible? Can somebody confirm?
Sir, you are.
Okay. Thank you so much, Dr. Devrari.
Thank you indeed, Dr. Durare, President NNF, Dr. Luigi, President IAP, Dr. Alpesh Gandhi ji, President Foxy, Lalan Bharti ji, Dr. Jyoti Sareen, President IANN, Ranjan ji, Dr. Nangia, colleagues who have spoken in the wonderful symposium, Ruchi, Deepthi, and colleagues. Indeed, I'm very pleased to be amongst you. This is the very leadership of neonatal healthcare in India. And today we are in the midst of newborn week. And today specifically, we are focused on prematurity related issues. We are devoting our time and mind and attention to the care of preterm babies. I'll like to make essentially 3 points for your kind consideration. I'm very happy that you have made today's focus as do no harm, which is very, very critical, because it is important for us that in our healthcare, and particularly in the healthcare of the most vulnerable of our patients, of our citizens, harm is not inflicted on them. And so important. And here actually we are proud that we have a positive story to tell the entire world. And that relates to how the ROP, retinopathy of prematurity in the country, has been addressed to a very large extent in a very positive way. I think we all paid attention to this. Our founding fathers of the NNF brought this to our attention. We worked together, we learned from each other, we embraced the best practices from the world. And together, today, we can say with reasonable confidence that ROP in India is not something that is excessive, if at all. We are doing better than many countries. We learned tough lessons, we were pained to see bad outcomes. But then I think here is a great story. And that also is to the credit of the National Neonatology Forum and Centers of Excellence in Neonatology, leadership of neonatology in the country to make that happen. It was a very painstaking affair. I just picked up that example to say that yes, once we are determined as a community and we work together, there is a positive change that we can be proud of. And this also goes to the fact that today the survival of preterm babies, low birth weight babies, sick babies is so much better than in the past. And we compare ourselves with the very, very best in terms of quality of care, in terms of understanding of newborn disease dynamics, and to be able to respond to that. My second compliment goes to you as a community who stood tall in COVID times. I compliment you for raising the voice about the care of newborn babies affected by COVID-19, having coming to them from their mothers. And you rose to the occasion. You looked at a systematic approach to tackle this problem for the diet, mother and child diet. You advocated for rational care, and you advocated for rational testing. And I'm very proud that you, compared to so many other disciplines, showed leadership in this area. So thank you for doing it. My next point and a request is a broad request that I believe that Pradhan Mantri Jan Arogya Yojana Ayushman Bharat is a game changer for the country, but it is also a game changer for newborn babies. Because for half of India's population, half of the babies of India's large cohort, birth cohort, is actually taken care of through Pradhan Mantri Jan Arogya Yojana. But if you look at the utilization of newborn packages, this is not the case. So I urge you today that let's connect to this opportunity, please, in all your states. As I'm saying, I'm repeating it again, for half of India's families, all the families, 65 crore people and about 13 crore families, for their babies, health care for newborn care, sick newborn care, normal newborn care is assured. And I know that we are not using these packages. So it pains me because very painstakingly working with you, sitting on this very table where I'm sitting today, we developed the packages which were optimum in terms of their payment structure, and that everybody knows that compared to some others where we may have been under placing. So I urge you that please find ways and means why our sick babies are not obtaining the benefits of PMJ. So that's my first request. And I would like to see this as a campaign to educate people, to look at which states are lagging behind. We can help you with data. Because there is no reason. Today, sick newborn care, premature newborn care is assured for half of India. It is a boon, and yet we are not using it. So can we please rise to the occasion? This is something which is so much within your grasp that we connect babies and their families to the paradigm of universal care for secondary tertiary care opportunities which the Honorable Prime Minister has guaranteed for this nation. My next point relates to going back to the do no harm paradigm. I'm very proud that over a period of time, this nation and you all have actually crystallized 4 or 5 key strategies which are and should be at the heart of our overall approach. Breastfeeding. Breastfeeding, the kind of movement we have in India for feeding small babies, sick babies with breastfeeding is amazing. Again, thanks to the value-based leadership that Neonatal Forum provides. Thanks for providing the evidence-based leadership, science-based leadership, and consensus-based leadership. So I congratulate you. Then this movement should pick up even more. We then collectively work together for scaling up kangaroo mother care. And we now believe in our heart of hearts how useful it is for the well-being of the baby and in ensuring breastfeeding access as well as reduction in sepsis and all the other goodness it brings. So thank you so much for embracing this as a principle, as a faith to be taken to scale. We are also the ones who embrace steroids and had a massive movement to promote steroids. I'm very proud that has done well, and I would like Ashok and your team to see how well we are doing. If there are any more scaling up required in a significant way, we have the honored presence of the President Foxy. Can we work together? Can we make it visible? Can we make sure that this boon is available to all the premature babies? And that could be one of the resolutions that you may like to take today. Also, family-centered care. You devised it. And we know how useful this is, how humane, and how culturally acceptable and culturally appropriate this paradigm of newborn care, which India crafted, not only for India, but also for the world. And another aspect that we have highlighted from time to time, for which there are many more milestones to be achieved, is the prevention of infection. I do believe we can do more by way of prevention of infection. Our best practices of hand washing, we all promoted that. But I think there is more that needs to be done to prevent sepsis and also to rationalize the use of antibiotics. I like on these two fronts our teams to work more and both prevent infection but also use the antibiotics with care. These are things that you and I believe in. These are the interventions which we live every day with. We teach, we practice. Our nursing colleagues, our doctor colleagues, our residents. So this is something that we stand by, and therefore these principles are aligned to the do no harm slogan that Dr. Devari has given.
I now like to bring to your attention something which I think should be an increasing focus. You all have seen improved outcomes. We all have seen improved outcome. And yet, going by the paper that our team, AIMS team had published 2-3 years ago, for preterm babies, the less than 70 MOQ, motor quotient, is 15%. There is a room for improvement to bring it below 5%. Motor deficits should disappear. We have done well, but more needs to be done. Mental quotient less than 70 is still about 5 to 6%. This is AIMS, by the way, and we think we should be reasonably good in this. And I'm sure there could be variations. Some of you may be much better than this. But I'm only making a point that this is the unfinished agenda, that we need to continue to push for the intact survival. Usually we relate that to brain. But I want to bring to your attention something which is less jazzy and less glamorous. And that relates to the issue of nutrition. Nutrition in terms of the nutritional outcomes. Here is the data from the same study. This is AIMS working very hard, all of us. That means new things have to be done, research has to be done. If you look at our cohort of how they perform at 1 year, these are the preterm babies who were at 0.7 Z, which means nearly at the median, nearly at the mean. At the age of 1 year, they were minus 1.6 Z score. This means they had 1.8 kilo less, or let's say 2 kilo less weight than the weight that they should have been at. 2 kilo less. They had 2 centimeter less head circumference, and they had 4 centimeter less height. And if we were to look at the Z scores at 40 weeks, post-menstrual age, this was actually at least double in terms of deficit, in terms of Z-score deficit, minus 4.6. The point I'm making is the following, that in spite of our best efforts, the nutritional outcomes are not optimal. It may be so in other countries, I don't care. And we have a different philosophy of nutrition, which is breastfeeding based and KMC based and home care based. So therefore, I want Neonatal Forum to think about how to optimize feeding. We are adding to the population of wasted and stunted children. These small babies, premature babies, these are, by the way, typically 31 weeks baby whose follow-up I'm talking about from Dr. Shuchita and Dr. Ramesh Agrawal's study published in the Lancet. So, in the process of looking after the babies and saving their lives, we are today, we were saving them, which is great, super. But also our next frontier is to save them with optimum neurological outcome, which we often talk, but we don't often talk about nutritional outcomes. So babies that we are discharging are suboptimal in their feeding. They are suboptimal in their nutrition outcomes. And if I look at the serum ferritin level, 74% of them had subnormal. So it's both macronutrient nutrition as well as micronutrient. Today is not the issue to go into the detail. I want to flag this issue that babies, surviving babies, are undernourished. They are forming the pool of stunted and wasted children. Even in the places where we are working very hard. And imagine suboptimal situations in our district, SNCUs and so on and so forth. So I request you that today, please think what more can be done by way of improved nutrition of the babies, which ultimately is breastfeeding, ultimately is kangaroo mother care. But how do we ensure? I've seen from one of the slides, Dr. Derari showed that breastfeeding rates can go up to 84% success, etc. Yes, there are ways of pushing the frontier. But we should be mindful of the fact that this is something which we don't accept as normal. We don't accept it today that this is good enough, that only 40% babies are breastfed babies and only 40% of their nutrient intake comes from breast milk. No. And if there are other scientific answers to this, It is not acceptable that a Indian citizen, Indian baby, an Indian girl, Indian boy, under our care today is 2 kilos less and 2 centimeter less in terms of the length and 2 kilo less in terms of weight. Please understand that height determines productivity and earning capacity. Head circumference is linked to IQ levels. Not acceptable. Undernourished children, even if they are less overall now, if they are less by even 2 IQ points, and our incidence being 1/3 of our birth cohort, we are less by 80 lakh IQ points compared to China. We should be not adding to that pool of diminished capability of our Indian children. So I want today, with most humbly, but with a lot of deep thinking, I'm requesting us to look at how we can step by step improve the nutritional outcomes of the babies in a systematic way, which means feeding, but it also means prevention of illness, preparing them to tackle diarrhea with zinc and ORS, etc., etc. So you discuss that, but I urge you to please pay attention to this. And I think UNICEF and WHO, you are also listening. There are many things that India has ignited and triggered in global debate, including the IMNCI and so on. So I urge you to kindly think about this as a challenge and see how much frontier can we push. We may not be able to bring back 2 kilos, but can we bring back 1 kilo in the life of a baby who reaches 1 year of age? With these words, I would give a final message, and that message is the following: that we have the vibrant home-based newborn care program. I think it should get your attention once again, apart from the PMJ that I mentioned. Can you please evaluate this program, how well this program is doing? Can UNICEF help us do an evaluation? How well are we doing across the country? It's now, started in 2011, I think I remember. So it is about 10 years. Can we see what improvements are required? Do we know that the skills are optimum? That is one area of work. And also, as you know, the home-based newborn care now flows into home-based young baby care, which means after 3 months, there are 3 monthly visits by the ASHA workers to promote health, nutrition, and development. So there is a mature program now in the form of home-based newborn care, and that's where nutrition is tackled. That is where at 6 months, complementary feeds have to be introduced, because only breastfeeding is not sufficient if you're looking at 1 year outcome. So even from that point of view, apart from others, I would urge that this is time for 2 things. One, evaluation and learning, but also importantly, I would request NNF to please connect with our ASHA workers and see that the original intent that was expected from home-based newborn care by way of care and skills and warmth and connect with the family and strengthening the ability of the family and particularly the mother, is that happening or not? If not, can we have a mission that we go back to a refresher training of our ASHA workers for home-based newborn care with focus on holistic development, holistic health, holistic nutrition of the newborn babies. With these words, I compliment you and congratulate you on the occasion of Newborn Week, occasion of World Prematurity Day, and I'm so grateful that you gave me an opportunity to speak to you. I commend and salute the leadership of maternal, newborn, and child health in our country. I commend the role played by newborn nursing. I'm very, very proud the way you have done. And I'm also here to help you if you think there is a time for pushing education. I think for neonatology, there is a lot of DM programs happening now. Tell us how much more we can do. We have allowed also nursing training opportunities. And if the time has come for nurse practitioner courses, let's work together. As Niti Aayog, my services are available to you. My partnership is available to you. Thank you so very much. Jai Hind. Thank you, Vinod, for your words of wisdom. We know prematurity, majority of the babies are about 32 weeks of gestational age, 85%. And what you said is totally right. These babies can be saved by breastfeeding, kangaroo mother care, use of antenatal corticosteroid, family-centered care, and preventing infection, and then reducing antimicrobial resistance. And we also agree to what you said. For very small, tiny preterm babies, neurodevelopmental outcome we have to be worried about. We need intact survival of these preterm babies. We need them, they thrive well, they are not malnourished, not stunted. So your words are for each one of us, for all the nurses, for all the doctors, pediatricians, obstetricians, and all the stakeholders. We will all work together for making sure that all premature babies, whoever survives and thrives well without any disability in times to come. Thank you all. It was very hard task for me taking 21 speakers and moderators on board for the last 3 hours. Thank you everyone for your time for this important cause on World Prematurity Day. Thank you. Thank you all. Thank you.
So Dr. Ashok Deora and Dr. Vinod Pandani and Dr. G, all my friends, for deliberations.
Thank you so much. Thank you. Thank you so much. We'll close the session now. Thank you.
Thank you. Bye.
Thank you.